So let's finish the remaining slides from mycology lecture. We talked about non-candida yeast-like fungi. So the most important non-candida yeast-like fungi that basically has taken advantage of our breaks in immunity and then some of the hospital acquired infections that we normally see, and these basically are considered as one of the important aspect for mycology, and they are mostly limited to one major pathogen, and that is Cryptococcus neoformans. So Cryptococcus neoformans has been there and has occupied different niches that we have, especially in food and water. And we know for our information of normal commensals that they are a part of normal human microbial flora as well. So let's take Cryptococcus neoformans in detail. So Cryptococcus neoformans is a encapsulated yeast-like fungus, and the name of the systemic mycosis that it causes is called Cryptococcosis. This fungus is present all over the world and is ubiquitous, especially in soil. And one important thing you have to keep in mind is that it is there in the droppings of pigeons. So pigeon droppings have that in abundance. If you want to look at the morphology of these fungi, Cryptococcus, they appear as typically oval with a capsule around and are in different sizes, anywhere from 2 to 20 micrometer. And the process of replication is budding, and that comes from narrow base. And then a single bud forms, and from there multiple buds are formed, and then you basically get a chain of budding cells, as we see in some other fungi as well. So the chain of budding fungi sometimes appears like a germ tube, as we discussed in Candida albicans as well. And sometimes it looks like a hyphae or pseudo hyphae. But pseudo hyphae and the other two germ tubes are absent in clinical specimens that we normally take from scrapings of these infections. And one other important thing that you have to keep in mind is that, as we've been talking about some special stains, so one of the special stains to stain Cryptococcus neoformans is India ink. So we have to prepare an India ink that basically would stain capsule and give appearance that you can see in this figure. As far as epidemiology is concerned, again, like many other fungi, they are there in environment and we inhale them, and that inhalation disseminates into the lung, and from lung it's carried to central nervous system and may produce clinical disease in some of the susceptible individuals, as we've been discussing in the past. Cryptococcus neoformans is pathogenic for immune competent individual, and this is a concept that we discussed earlier, because sometimes even a fungi is non-pathogenic, but your immune system is compromised, that will cause you a clinical disease. But in this case, this happens to be a pathogenic, and even if you have a normal immune system, you may get problem. This also happens to be the most common cause of fungal meningitis, and especially for those people who have defective cellular immunity. So that's one thing special for this particular fungi that you have to keep in mind, the cause of fungal meningitis. This is a natural history of saprobic and parasitic cycle of Cryptococcus neoformans. Again, you can see pigeons, bird droppings, you inhale them and they go into your system, and that's where the clinical disease will begin. And most commonly, what we see is a typically lung infection we call pneumonia or pneumonic process. And then again, CNS infection can occur when this fungi goes via blood or lymphatics from the primary pulmonary focus. Very less often we see a more widely disseminated infection, and that can come along with cutaneous, mucocutaneous, osseous involving bone, and visceral form of disease that may involve any viscera or organs. As far as pulmonary cryptococcus is concerned, typical presentation is that you have a asymptomatic process to all the way to a fulminant bilateral pneumonia. So you can see as no infection at all, you remain asymptomatic, and on the other spectrum, you may have a fulminant, full bilateral pneumonia involving both lungs. Lab diagnosis is done by culture of the blood, cerebrospinal fluid, or any other clinical material that you may get. We have to look under the microscope, and under the microscope, you will see that they appear as characteristic encapsulated budding yeast cell. Very commonly, we see that we have to look for the capsular polysaccharide antigen in the serum or CSF. So that's more or less diagnostic test for that. And we already talked about the India ink that would cover that up or stain that up. So that's important for us to know. Lastly, Aspergillosis. Aspergillosis comprises a broad spectrum of diseases by this member, Aspergillus. And again, it is there in the environment, and people may show allergy to that. And especially if you happen to be sensitized to that, you may see an invasive pulmonary or disseminated disease, especially if you have a compromised immunity. So Aspergillosis is the name of disease that we get from Aspergillus. It's common throughout the world, and their conidia are there in air, soil, and decaying material. Within the hospital setting, they may be found in water, in air, in shower heads, and the potted plants that you may see infection coming from. If you want to look at their morphology, they look like hyaline molds. The colonies of Aspergillus may appear as any colored, basically black, brown, green, yellow, white. It depends upon the species and the growth condition. If you look at the colonial appearance, it provides an initial suggestion that it could be one of the species of Aspergillus. But obviously, definitive treatment requires microscopic examination, and you have to look at the hyphae and the structure of the conidial hull. And this will basically give you a typical, we call a cotton blue preparation showing conidial heads. So these are the small little conidia that will get dispersed in environment and you can inhale. This is another important cotton blue preparation showing conidial heads. Now, if you look at the spectrum of diseases caused by Aspergillus species, you will see a very widely distributed reaction, all the way from allergic reaction in the nose, sinuses, and even lower respiratory tract. They can colonize in our paranasal sinuses and move from there to bronchi, and then may go further down and form preformed pulmonary cavities. They can also cause some of the skin infections, especially in wounds and catheter sites. And then they can also cause a little bit limited invasive mycosis from bronchi, pulmonary parenchyma, and then mildly immunodeficient patients may show these invasiveness. And finally, a full-blown disease will show as frankly invasive pulmonary infection, especially if you are immunocompromised. In this case, it will spread all over, disseminate, and even cause the death of the patient. Now, how do we treat and prevent it? You have to be careful, especially when you're dealing with high-risk patient, as we've discussed before. The other important thing you have to keep in mind is that if you are neutropenic, meaning that you have less number of neutrophils, and of course you happen to be a high-risk patient as well, they have to be housed in special facilities where the air comes filtered and the filter air is there to minimize exposure of those conidia that are disseminated from Aspergillus. The last of the series of these infections, Zygomycosis, and again it is caused by fungi in the class of Zygomycetes. These basically will give a chronic granulomatous infection of subcutaneous tissue. It happens, the disease happens worldwide. The most common cause of human zygomycosis is Rhizopus arrhesus. So Rhizopus arrhesus is the most common type causing human disease. If you were to look at a typical sporangium, you can see it is a sporangium, and within the sporangium there are rhizoids. And morphologically, if you look with a naked eye, they appear anywhere like a typical gray to brown woolly colonies, and they form within hours. Then you have to look at genus and species under the microscope. They may appear as mold with broad highlines, partially septate, co-anocytic hyphae. So these are important characteristics of zygomycosis. Typical clinical picture that we get, and a very scary one, is rhinocerebral zygomycosis, which is acute invasive infection of nasal cavity, paranasal sinuses, orbit, and involve the facial structure, and that can extend to CNS. I will show you a case in my clinical presentation where there's a patient and all his eyes, nasal cavities, and oral cavity was involved, and they did surgical removal of all these openings till he was left with faceless features. And even then they weren't able to control it, because once it goes into your meninges and brain, it will be very difficult to treat them. These kind of infection happen especially in diabetic patients, especially when they go through metabolic acidosis, and some of the patients who have blood cancers like hematologic malignancies. As far as lab diagnosis is concerned, as we discussed earlier, they have very poor prognosis, and we have to try our best to treat them and look at the microscopic picture, histological structure, and culture. The treatment of choice as the first line of therapy for zygomycosis remains as amphotericin B. So amphotericin B, but again, as I said earlier, I will also show you a case where they tried to supplement amphotericin B with surgical debridement and tried to give help in terms of immune reconstitution. But unfortunately, that particular patient that I'm talking about did not survive. So you can see from here that fungi that we normally have never heard of sometimes may pose a serious problem in high-risk patient who are either bedridden, have compromised immunity, or on constant steroids like organ transplantation, bone marrow transplantation. And then we have to really go and try all our antifungal therapy plus surgical intervention. And if we can also reconstitute their lack of immunity in terms of whatever is deficient, we can compensate for that and try to help them. But unfortunately, for most of the patient, that's not helpful, and the mortality rate is pretty high. Okay, I'll finish with this, and then after this, we will have some clinical case presentation and discussions in the class. Thank you.